Top Med Talk.
This piece features Sol Aronson, tenured professor at Duke University and a Top Med Talk regular. It was presented first at EBPOM 2020, live from London.
I was invited this year for EBPOM London to present to you some of my thoughts on prehabilitation, or the business case for why I think it really is sort of a non-question, a non-issue, if you will, a slam dunk. And allow me to sort of walk you through what has now become more of a reality for those of us who are practicing perioperative medicine and perioperative care in the United States, and perhaps more familiar to you colleagues in the UK and Europe. Surgical care in the US, I think, is an interesting place to begin, just to lay some foundation. We do in this country about 50 million surgical procedures or invasive procedures that require hospitalization a year. That's a staggering number. And another interesting number that sort of makes you pause and sort of roll your eyes and sigh perhaps is the average person in the US will undergo about 9.2 surgical procedures in their lifetime. Obviously that's stacked toward the latter part of your life, but nevertheless, that's a lot of surgery. And as we know, and we've been familiar for many years, surgery is a disproportionately expensive healthcare encounter within that continuum of healthcare in our life cycle. It accounts for about 29% of hospital admissions, and yet it accounts for over 50% of the cost or expense. And that's just routine. When there's an adverse event or a complication that is attributable to a surgical procedure, that also escalates significantly, almost in a disproportionate significant way, the cost of care. The average complication ranges anywhere from $8,000 to over $40,000, depending on if you're looking at a surgical site infection, not an uncommon, if you will, event after surgery, to a post-operative pneumonia that requires ventilation. The average cost of a hospital stay, of course, that varies by region in this country, is about $16,000, and that's significantly dependent on the region of the country, the zip code, if you will. And one of the things that we found here at Duke, and has since been reestablished over and over again by a number of sample surveys, if you will, in patients who are being brought into the surgical sort of domain because of their declaration of surgery, is that up to 20% of people who are going to have surgery, declared surgical, if you will, are not ready for surgery. If you look at how we can optimally meet, if you will, their needs for medical management of their comorbid medical chronic conditions. And so the opportunity for us to get those people who are declared surgical and should be invited to have surgery, and we're obviously talking about elective surgery, best suited for surgical care is the focus of this discussion, and I think where we can really bend the curve. Obviously, we're not talking about emergencies and emergencies. Those are dealt with urgently and emergently, but in the elective surgical domain, 20% of people who are scheduled to have surgery are not ready for surgery. Little history before we jump into the economic rationalization. I think this is relevant because we have done so much as an intended, if you will, disruptive maneuver of changing the paradigm of healthcare, but sometimes there are unintended consequences of the intended, if you will, disruptions that we introduce into the system. As early as the 1950s, the first report of an anesthetic outpatient clinic was introduced by someone in St. George's Hospital in London. Very interesting. We're going to get back to that in a second. In the 70s, in this country, a couple surgeons in Phoenix, Arizona, were the first to really introduce the concept of ambulatory surgery center. And it was really out of necessity because they weren't getting the access and services that they wished for in terms of wanting to have block times and as such. And so they introduced this concept of an ambulatory surgery center. And I think that has been a very important hallmark in healthcare delivery in the world, if not in this country. In the 80s and 90s, when I was a resident, we really had preoperative assessment be routinely performed the night before surgery. It was very common for me to get a list of the patients that I needed to see the night before, and I would go and visit them as they were already admitted into the hospital, and we do our H&P and do our preoperative assessment by basis of a night before rounding. While this was going on, of course, in the 80s and 90s, ambulatory surgery continued to grow as an entity. In the 90s, I think the concept of same-day admission became much more common. It was a way to really reduce the bed utilization and to sort of free up some of those beds that were becoming more and more recognized as necessary. And because people were now coming in the day of surgery, this concept of pre-anesthesia testing clinic emerged. And so this was the first introduction that we had to really addressing the need to still see patients and evaluate their, if you will, readiness for surgery by the virtue of this pre-anesthetic testing clinic in the early 90s. In 1997, Dr. Helmut introduced the concept of enhanced recovery after surgery. This has become a mainstay in our practices today, and it was first introduced in the latter part of the 1900s. 2000, we saw more and more disruptive forces come into surgical care, non-invasive surgery, enhanced recovery protocols, and all along ambulatory surgery became even more and more prevalent, probably representing greater than 50% of all surgery. 2010, I would say, was characterized by an emphasis on episodic care, bundling, if you will. Functional recovery became more of a mainstay. And of course, enhanced recovery after surgery became a standard of care in the practice of medicine and perioperative medicine in this country. About 5 years ago or so, we introduced a concept called the perioperative anesthesia and surgical screening clinic and the perioperative enhancement team, the PASS clinic and the POET programs, to address some of these issues of unmet need to deal with these chronic comorbid conditions of patients that were having surgery but not yet optimized for surgery. And all along throughout the latter part of this decade, we continue to see increased external tensions of value propositions of external market forces to really help us become more effective and efficient stewards of value in healthcare delivery. These are a few quotes, and I think they really are elegant in that they characterize from the decades that have passed the sort of cultural, if you will, color, flavor that characterized perioperative medicine. In 1949, Dr. Lee wrote, "I think that an anesthetic outpatient department could contribute considerably to preventative medicine. The anesthetist is frequently confronted with a patient who is not in the best possible state for operation. He has not been made as safe for surgery as possible. For the anesthetist to see the patient the evening before or even 2 or 3 days before is not enough." Prophetic, nearly 70 years ago. In the 1999, Dr. Kellett wrote, "Preoperative evaluation and care are essential for optimal surgical outcomes and provide health benefits long after surgical intervention." And last year I wrote an editorial and I spoke to the need for us in this country, if you will, to address the issue as to whether medical optimization should be achieved before surgery is not debatable. The importance of risk mitigation to enhance postoperative value is not in question. What is the best model for preoperative optimization and achieving value, however, remains untested in part because of the alignment of short-term interests with long-term interests among patients, providers, and hospitals is a hurdle our current culture has not undergone sufficient transformation to get over. What did I mean by that? What I meant by that is that we still, for the most part in this country, are paid for our complications. The incentive for us to tee the patient up optimally so that we mitigate downstream adverse events, though, is exactly what we should do, and it would be argued perverse not to do that. Unfortunately, the economic incentives are not aligned with that behavior because we still, for the most part, in a fee-for-service healthcare environment, get paid for our complications. To bend the cost curve and to impact value, we must reduce the waste, we must reduce utilization, and we must increase care coordination. And that's true throughout all of healthcare, but certainly it is applicable in perioperative medicine. We have to reduce avoidable adverse events proactively, not retroactively. And we have to recognize, and this is where it becomes tricky in some of the C-suites, that downstream return requires an upstream investment. And that's where perioperative care as a preventative measure is really important. And I think another issue that we won't have time to talk to today, but I think it's really critical, is that the social determinants of health probably represent 70 to 80% of the real opportunities for us to reduce costs and enhance value in population health. So if we just focus now on the preoperative assessment and the pre-anesthesia testing clinic, if you will, I think there are a number of what I call economic tiers or motivations to have preoperative testing. The first tier has been reported on for decades, and it really is well established now that if you see a patient before their surgical day, that you'll reduce surgical delays on the day of surgery, you'll reduce postponements and cancellations. And this has been reported over and over again, and has been the sort of mainstay, the foundation to justify preoperative assessment before the patient arrives to the operating room or the hospital on the day of their surgery. A second very important tier in the economic, if you will, continuum is that we also know that when you have better care coordination by seeing patients before their surgical procedure day, is that you'll reduce waste. You'll reduce the redundancy of labs and diagnostics that are ordered, and again, it represents a significant cost savings. The third, if you will, tier is what I'll call contribution margin, that we, even in a fee-for-service world, still are recognized for the work we do in coding and getting payment for some of those events. And whether we code that as a visit or a return visit or a transition of care visit, or if we go on to enhance the medical condition by sending them to an anemia clinic or to have nutritional optimization, on, we can get paid if we code for those, and it's appropriate that we do. The fourth and the fifth economic tiers for, I think, the best rationalization for preoperative care and preoperative management have to do with what I call cost avoidance and population health. I don't think we're going to have a lot of time to talk about population health today, but cost avoidance is very, very important, certainly, and dwarfs, if you will, all the other, if you will, economic drivers that I just spoke to above that. So why all of a sudden now are we focused on cost avoidance and population health as metrics and drivers to motivate our behavior and paradigm change? This is a cover of a journal, the Journal Anesthesia and Analgesia. I think it was the April issue that we were fortunate enough to get the cover art after we published a few articles in this journal that really sort of illustrates that sort of choice that one makes between deferring an elective surgery to optimize the patient's medical conditions in order to enhance their downstream outcomes and reduce their downstream costs versus going forward expeditiously, perhaps having to balance that impairment for surgical need. And that's a science unto itself that's very nascent, very if you will, sophisticated in that we still have a gestalt in that we balance that decision all the time, every day. Should we go forward with surgery or should we postpone surgery? And I think though we all work to the best of our abilities to make that decision appropriately, I think it's also important to recognize that there's very little science to sort of drive that decision. It's important that we look into that area much more carefully in the next, if you will, few years. These are data that I show in many lectures, and I think they very nicely illustrate that we are a population of people who are getting more and more elderly and more, if you will, sick every day. In the United States, the proposal is that probably 25% of us, by the time we've reached our 65th birthday, have at least one chronic comorbid medical condition. And if that's 50% of us that have at least one, it's 25% of us that have at least two. So we see this every day, and the likelihood that we're going to continue to see people with chronic comorbid medical conditions is only going to get greater. How we relate the existence of those comorbid medical conditions to the likelihood of an adverse event during surgery is really where the science needs to be evolved. Costs of post-op post-operative complications are very real and they're very expensive. Data from many years ago looked at a average cost of an additional $12,000 or so US dollars to any complication. You can see that there are many, many studies, some in the States, some in the UK, some all over the world, that have related and addressed the likelihood of complications based on predictors of medical comorbid conditions. And when that complication occurs, it simply enhances the cost of the procedure exponentially. So when you're in an environment where healthcare is expensive and the means to pay for it is a continuous external factor to push the curve of expense down, and we've been seeing this in the States for years. We've been talking about it for every generation and every election cycle, and it hasn't gone away. In fact, in this last quarter, we've seen an exponential enhancement in that cost curve because of the COVID crisis. Our unemployment rate has seen records that it hasn't seen since World War II. And all along, the reality of cost of care has continued to escalate. We spend too much in the last decile of life, and we're seeing that our employer and employment contribution is just a burden that is too heavy to bear. And so the reality is this is an inevitability that we will continue to see a shift of risk bearing in our country, which is going to be more and more familiar to you in the UK, where the physicians and medical groups, the hospitals and the providers are going to have to bear the burden of assuming that risk. So how do we address this? This is, unfortunately a problem that we've been talking about for years, but I think the reality of value-based care is becoming more and more relevant every passing day, every passing month in this country. So here we are. The cost of care is too much. When we stick with a fee-for-service model, we unfortunately, in a perverse sort of way, get paid for the complications that we're no longer going to be able to enjoy going forward. And so we have to figure out how to responsibly bend that curve. How do we invest today for downstream return? This is a model that we proposed about 5 years ago. It's basically taking that perioperative medicine domain and really looking at how we can begin to introduce proactively means to change medical comorbid conditions upstream as soon as there's a declaration of surgery. And so if we focus just for the next few slides on what we've been doing in our pre-anesthesia and surgical screening clinic, I'd like to speak to that a little bit. This is a drill down sort of slide of what that process looks like. Rather than having a patient go right to surgery after there is a declaration of surgical need, we now try to get that patient as far upstream as possible so we can do an exhaustive evaluation of their medical, if you will, readiness to withstand the perturbation of surgery. If they're healthy enough to go forward, we fast track them onto surgery as we normally would. If we, on the other hand, learn that they have chronic comorbid conditions that are modifiable, we defer them to one of a number of optimization clinics. We call those POET clinics or perioperative enhancement team type of clinics to manage their anemia or their diabetes or their nutrition health status, et cetera, et cetera. That makes sense. I mean, preoperative anemia is just an example of why we would want to do that is, of course, common. It ranges, and the study that you might look at from 5 or 10% to 60 to 70%, depending on the population you are looking at. It's a known predictor of morbidity and mortality. It's a significant predictor of intraoperative transfusion, and intraoperative transfusion unto itself predicts morbidity and mortality. It's expensive, and it's associated with significant increased costs, not to mention the direct costs from the transfusion itself, but the indirect costs and sequelae of anemia and or transfusion as a consequence of the procedure. It also makes whatever other, if you will, medical conditions that you might have exacerbated in their likelihood to predict adverse events. And so anemia is very common. It's very bad for you. And it certainly is a target where many of us have focused our attention on trying to understand how we can treat that preoperatively. But sometimes that's expensive. Sometimes it's expensive to delay the procedure in order to make the argument to treat anemia. And that can be emotionally expensive as well as practically expensive. You have to set up an anemia clinic that requires capitalization, that requires personnel, that requires all kinds of other, if you will, expenses that one has to accept as something one can incur as that upstream investment to support a downstream return. And so we did that, and as far back as probably 4 or 5 years ago, we began to track our outcomes of people who were sent to our preoperative anemia clinic. As you can see from this bar graph, it really didn't matter what surgical service they came from. Basically, when they met our threshold criteria for anemia, not necessarily a World Health Organization definition, but our definition, we were able to show a definitive increase in their hemoglobin or an increase in their ferritin when we were able to bring them into our preoperative anemia clinic and diagnose the etiology of their anemia and treat them. And like many others in this space, we also tracked, if you will, whether or not we could reduce the amount of blood transfusion as a consequence of this preoperative effort to treat their anemia. And these are just some data that we presented. They're not dissimilar from other people who have presented similar data, where we're able to show that we, in this particular study in joint surgery, we're able to reduce transfusions and have that patient be discharged after surgery with a higher hemoglobin to enhance their functional recovery. But the part of the story that I think is most interesting and heretofore not reported by anyone is what is the, if you will, consequence of the cost avoidance outcomes of treating anemia. And in the myriad of data that exists in preoperative anemia clinics, no one has yet, so far as I know, presented these data in this way. And so what we were able to do by mapping these to our electronic health record and Vizient model of outcomes to a nomogram of others is we looked at all the patients that we were able to identify who are worthy of being treated in our POET anemia clinic. And we compared those to a similar population who were equally worthy, but for whatever reason refused to be treated because they more likely than not had refused on the basis of inconvenience, too far to travel. They didn't want to come back to the hospital to get infusion treatment, et cetera. And so when we compared those groups and we did a regression analysis to match them, and they were similar with respect to age and baseline hemoglobins and their case mix index and their ASA levels, we found that the people who we sent to our care coordination program for anemia management, our POET anemia program, if you will, had a significantly reduced length of stay. And they also had a significantly reduced 30-day readmission and intraoperatively ICU admission. That's really noteworthy. And so far as I know, that's the first time that these kinds of outcome data have ever been reported. And so now we're talking about the cost avoidance value proposition of preoperative management of comorbid disease that is significantly more described than heretofore in process outcome variable ways. So we're not just increasing hemoglobin with a supposition that that's good for you, but we're actually showing that because we increased hemoglobin, we were able to reduce their stay in the hospital. We were able to reduce the likelihood that they would be readmitted at 30 days, and we were able to reduce the likelihood that they would be able to need a ICU admission. What we also showed, and this is interesting, is that it was time sensitive. The longer we had to treat their anemia, the longer the runway before surgery, the greater the impact we could have on the hemoglobin change that we found. That was greater early on, and interestingly, it plateaued at about 2 months. And so there really wasn't any advantage to treating anemia beyond 2 months. There was a diminutive effect. And so if you were trying to understand what would that ideal window of time be, it's probably between 2 weeks and 8 weeks before surgery is when you would want to have a patient who was diagnosed with anemia come into your clinic to get iron or erythropoietin infusions. We're actually able to show that for every day of treatment, it was associated with a length of stay reduction of about 0.01. And the higher that change in hemoglobin, the greater the likelihood that we would see a change in the length of stay. So for each unit increase in hemoglobin change, we had an associated almost a half a day reduction in their length of stay. And so we could actually quantify it in the respect of now if you're trying to balance what is the risk versus reward of postponing an elective procedure who we now understood is going to be done in a patient who's anemic versus going forward because you would argue the impairment for surgery is high. You can actually quantify that with respect to knowing that for every, if you will, increase in hemoglobin change, you can reduce the length of stay by a half a day and begin to make some very sophisticated cost analysis for that return on investment. Similar story for diabetes. So hyperglycemia, we know for years and decades portends postoperative adverse events. It's common, certainly in the general population. It's very common in people who undergo surgery. And it is a predictor of adverse events, albeit they infection or acute renal failure, as well as prolonged length of stay and mortality. Interesting, many people in our experience has probably been up to 10 to 20% of people who we determined to have poor glucose tolerance in our past clinic don't even know they're diabetic to begin with. And so we did the same thing when we met threshold criteria from our past clinic evaluation. We would divert these people to a preoperative diabetes management clinic when they accepted, if you will, that recommendation. And we were able to show that we significantly decreased their blood glucose or their hemoglobin A1C, whatever metric of process outcome we would measure. And sometimes that was something we were able to do within a few weeks. Often it would take us probably 4 to 6 weeks to see that optimal effect. When we measured the consequences of that preoperative, if you will, aggressive management of diabetes, we again here showed that we had an impact on their 30-day readmission rate, as well as some very strong signals to decrease some of their hard outcomes like acute kidney injury, myocardial infarction, and AFib after surgery. One of the things that we are really excited to report, and this speaks to the population health side of the equation, is that not only were we able to show that change in their hemoglobin A1C from their pre-surgical to their day of surgery after they had their POET intervention, but that had legacy, that had memory. And that when we measured the hemoglobin A1C in these people 3 months, 6 months, 12 months, and even 24 months after their surgery, we saw that their hemoglobin A1C was still sustained down, significantly less than it was when we first saw them. And so there's some kind of a teachable moment or a lifestyle change that we're able to induce here. And I think that's something that we're very excited to track, and we're going to continue to monitor that going forward. And we've recently introduced some remote patient monitoring tools in our past clinic as well to help with the fidelity of monitoring their perioperative glucose. I'm going to tell the same story again for malnutrition. We know that malnutrition is a strong predictor of adverse outcome. It's common. These are some very lovely slides from Paul Wishmeyer and the POKI group that really illustrate that 2 out of 3 patients coming for GI surgery are malnourished. It's sort of a stealthy kind of adverse a predictor because most of us don't know that we're malnourished. When we are, it predicts death, it portends badness, as well as increasing in costs and length of stay. When we look at those patients that we bring into our past clinic for presence of malnutrition, and we use a PON score, things like their weight, their diet, their weight retention or weight loss, as well as some laboratory findings as a screening tool to send them for a much more exhaustive evaluation by a registered dietitian. And then we based on their diagnosis of malnutrition, would treat them and according to some of the menu that you see here on this slide. Here again, what I can report to you is when we do that, when we are able to proactively and prospectively identify these people with malnutrition and look at them after treatment with respect to their index length of stay or readmission rate and compare them to a controlled group that has been matched, their length of stay is less, their readmission rate is less, and their signal for end organ damage is significantly less as well, though our data isn't powered yet to make that statement in a statistically significant way. But we're very, very excited about these data because they point to the same thing. I can go on and on. The same story is true for smoking. Smoking, as we know, portends significant adverse outcome. It's common in the United States, probably even more common in the UK. The physiology and biology of smoking has been well described and well studied, and smoking has been shown to significantly impact perioperative outcomes, increases morbidity, increases mortality, cardiac and non-cardiac surgery, and this has been repeatedly shown over and over again. When we are able to identify people who have a history of smoking and convince them to enter our smoking cessation program, which is a unique program in that it really takes into account the personal, if you will, behavior modifications of every patient based on their own individual history, and isn't just sort of prescriptive like some of the quit lines or self-directed quit programs. Our recidivism rate in our smoking cessation program is significantly more impressive than some of the 1-800 number lines that you can get. Be that as it may, I think when we start to do the economic analysis of our smoking cessation patients, we're able to show that there's some very hard, if you will, return on investment. Probably about $8,200 lifetime cost savings to the Duke Health per patient that we are able to treat from our smoking cessation program. And if you start to multiply that by the number of patients that have finished the program, these numbers add up very quickly. And so here again, the return on the the upstream investment has justified the downstream, if you will, return. This is a chronic pain program that we call Partner. We've introduced sort of a functional recovery that combines a psychiatric evaluation with a pharmacologic management of people with chronic pain syndromes. These are the patients that are the high utilizers, the ones who come to the hospital frequently. They are probably visiting the ED 20, 30 times a month. When we introduce this program into this population, we're able to show that we've significantly changed, if you will, their behavior. Their inpatient visits have decreased significantly. They're able to be managed much more effectively as outpatients. And the consequence of that now, about 3 years into it, is that we've saved nearly $2 million for the institution. Here again, an example of how upstream investment has been able to show downstream return. So these data are data from a number of studies in the U.S. that demonstrate the cost of a day for a hospital bed. They range anywhere from $1,500 in Montana to $3,500 in New York State, but the average is about $2,300 a day. If you're in the ICU, it's obviously a multiple of many times that. Readmissions are obviously something that other health economic experts have studied, and our data have helped us understand that a readmission can be as much as $15,000. And of course, if you have an acute kidney injury or myocardial infarction event, that unto itself is a very expensive undertaking. And so doing the health economics of how we can upstream reduce length of stay for hospitalization, how we could reduce the likelihood for readmissions are things that we're now studying in a health economic way to understand what is the true economic return for the kinds of work and the kinds of things that we do preoperatively. So the economics of perioperative medicine are not just first tier reducing case delays or case cancellations or redundancies in the tests and diagnostics that we order. But it's also important to understand that in addition to the contribution margin that we may get for the services rendered in a fee-for-service world, the real bingo, the real return is the cost avoidance, and the economics of that are staggering. So I think this is a slam dunk, and that the value proposition for perioperative medicine should be something that is no longer debatable, but rather now moves into the zone of true science so that we can better understand how to make those decisions on a day-to-day basis about whether or not to postpone or to go forward based on the value that we create for the situation. I really appreciate the opportunity to speak with you, and I look forward, I hope soon, to share a beer with everybody in the auditorium. Thank you very much.
Top Med Talk. Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.